The first speaker, we're going to do a fireside chat, but the first is actually Celiac New Zealand's patron. So I hope most of you actually know this person, but he's also the recent recipient of the Celiac Disease Foundation Award Prize for Excellence in Celiac Disease Research, recognising his contributions over the past 25 years. He obviously started when he was 15. But Dr. Bob Anderson is a gastroenterologist, an immunologist, and a drug and diagnostic developer specialising in celiac disease. He is the current president of the International Society of the Study of Coeliac Disease. And this year he was awarded the Research Excellence Prize by the Celiac Disease Foundation in the USA for contributions to understanding celiac disease. Bob studied medicine and then completed his PhD at Otago University. I'm sure that's not all you learnt at Otago University. Before training in gastroenterology at the Royal Melbourne Hospital, he then spent 4 years as a specialist at Oxford University, focused on vaccinology and discovering the specific gluten peptides responsible for celiac disease. Returning to Melbourne, he launched the Celiac Disease Lab at the Walter and Eliza Hall Institution, and then gradually shifted focus to leading the commercial development, exploring the effect of prebiotic complementary foods on the microbiome composition in infants. Seems to be a real theme of looking after the infants. It's fantastic. He also has a daughter with celiac disease, is now leading development in the diagnostics for celiac disease and other immune conditions at Novoviah Pharmamceuticals, and is also in clinical practice in sunny Mackay, Queensland. Join me in welcoming Bob Anderson to the stage. Jason as well, absolutely. I hope I pronounced everything right.
Pretty good.
Pretty good? Yeah, there's some improvements probably. I can have a debrief. Our other keynote speaker is Associate Professor Jason Tye-Din. I have actually heard him speak before. He's excellent. He works closely with academic and industry partners and runs a wide range of projects, including development of a novel diagnostic blood test, a non-invasive monitoring for the gluten-free diet, examining the safety of oats, the role of microbiome in the symptomology, and developing and testing a range of new celiac treatments. Jason runs a celiac clinic at the Royal Melbourne Hospital, where he manages people with celiac disease and gluten-related issues, including many with non-responsive and refractory disease. He leads the celiac theme of the Australian ENDIA study, examining the environmental factors important in the development of triggering of celiac disease. I actually remember you saying you were not in a hurry to take your son to Bali for a trip, actually, Jason. Jason, if you would like to come up and join Bob on the stage, please, as well. Now, I'm going... Thank you very much. Microphones. Yep. And just a reminder, the questions, if they can come through, Rosie will be happy to mediate. And we'll just probably start with some opening remarks from you both. And we'll start with you if you don't mind, Bob.
So I'm Bob, and I grew up initially in Takapuna in Auckland. And then when I was 14, I moved to Dunedin, where I spent 16 years in the end. And then I moved to Australia, trained in gastroenterology for 6 years, and then had this really interesting journey in celiac disease, which began when I arrived in Oxford as a postdoc. So you're faced with really trying to become a mature scientist when you arrive somewhere like Oxford at that stage in your career. And really by chance, I flipped from working on inflammatory bowel disease, Crohn's disease, over to celiac disease. And it was really because I wanted to understand the immune system. And the group I ended up with was the lab that developed the Oxford COVID vaccine during the pandemic. So I had this really quite unusual experience for a gastroenterologist working with people who develop vaccines. And that gave me a very different perspective from, if you like, the average life of a gastroenterologist looking in bowels. And I became really interested in T cells. And it turns out that T cells are really the key to understanding many diseases, because this is really how do you drive what we call acquired immune responses. So celiac disease is an acquired immune response against gluten. And I inherited a project, and as a researcher, you often inherit projects that are wrong. And the project I inherited was wrong, but it took me about 6 months to work that out. And then I had to try and work out, well, what was the right answer? And the question being asked was, what's the trigger? What is the fragment of gluten that triggers celiac disease? And so, cut a long story short, it turned out that there were trigger peptides, and they were consistent amongst everyone with the standard genetic background for celiac disease. And a group in Norway had been working on this for many years, as had many others, and they had arrived at the same answer. So this was a wonderful conjunction of research groups working independently, came up with the same answer, but it effectively unlocked, if you like, the new age of celiac disease, which was saying rather than talking about gluten as the toxin, it's really the fragments, the particular fragments of gluten. And that opened up things like better food testing, developing therapeutics, vaccines, diagnostics, all sorts of things, all depended upon this very reductionist, what fragment is it, and chemically defining it. And so then I went back to Melbourne, set up the lab, and then Jason and I met, in fact, in Footscray in Melbourne, I think it was, Jace. Yep. I was the medical registrar before celiac disease. And Jace, I think you were your 5th year at medical school? Yeah. Anyway, so we go back a long way. And then he joined me as a PhD student. I stayed for 10 years, began to get more interested in developing drugs. And then Jason took over running the lab when I left for Boston in 2012. And we've had this really deep, long-term relationship, which has been great. And I sold him my house. So, yeah, we have a lot to share. But Jace, over to you.
I should say we had to do some significant renovations because all of the benches were like this high and were like needed to shift it to normal height. So yeah, I mean, it's been a serendipitous interaction. My initial PhD was to go up to Sydney and work on autoimmune hepatitis, but due to some health reasons with my mum, I stayed in Melbourne, and I was fortunate enough to work with Bob under his leadership on understanding those parts of gluten that trigger celiac disease. And I suppose my life now is very much 80% research and 20% clinical. So 4 days out of the week, I'll run a research team. There's 9 of us at the Walter and Eliza Hall Institute, and we undertake a range of research projects. We're very interested in developing better ways to diagnose celiac disease, and we'll touch on that today, particularly ways to diagnose it in people who aren't eating gluten actively, and also understanding the triggers that are behind the development of celiac disease. Why does it develop in some people, and why do some siblings not develop celiac disease? We're also very interested in understanding the mechanisms for how symptoms are triggered by gluten, and again, why do some people get vomiting and nausea and diarrhea, and some people can eat lots of gluten and not overtly have any symptoms. And we work very closely with a whole range of different collaborators, including other academic groups and groups like Bob's who are developing new treatments or diagnostics for celiac disease. And again, we'll touch on some of that today. And then the other day per week, I am seeing patients in a celiac clinic or in my private rooms, and really the focus is around people with gluten-related issues and trying to get a diagnosis of celiac disease, or more commonly, managing people with celiac disease who just aren't getting better on a gluten-free diet, the so-called non-responsive celiac disease or refractory celiac disease. And I know we'll be hearing a little bit more from that today by Adele, in fact, after this session about the dietary management of that. So it's a bit of a mix, and I love that mix of research and seeing patients. And yeah, so I think that's kind of where things are at with me at the moment.
So we were just talking, as Sam was saying, we were talking out in the dining area about where is celiac going, and where are we now, and what's the past? And so, Jason, in terms of your day-to-day lifestyle, it's probably unhealthy, but what do you actually do during a normal week? And what are the big problems that you see in celiac disease world today?
I think some of the common challenges would be people have started a gluten-free diet prior to getting formal testing for celiac disease, and then asking them, oh, you need to go back onto gluten for 6 to 8 weeks or longer in order to get a diagnosis. And whilst the gene test is helpful for some people, if we do the gene test and it's negative, we can exclude those people as having celiac disease. For those who do have the gene, then doing a gluten challenge is understandably very challenging. Many people can't tolerate it. It can cause really adverse symptoms. So getting a diagnosis is a major issue. I think more broadly, people who have persistent symptoms who just don't even get tested by their doctor is a major problem. We know that depending on which country you're in, it could be 5 to 10 years or more before you actually, if you're lucky enough to get diagnosed, get tested for celiac disease. So there's that awareness factor. And also a big issue are people who follow the gluten-free diet very strictly, but they still have persistent gut damage, or they still have some persistent symptoms. And I think working through the causes of that can be very difficult. So I think there's a real need for better diagnostic approaches, but also better diagnostic tests. And I think that we're starting to really appreciate the limitations of the gluten-free diet. Even when people are doing it strictly, not everyone gets the outcomes, and we heard that very nicely with Karen's previous presentation. And so I think there is the need for novel approaches or better approaches that either support the gluten-free diet or maybe one day replace it altogether. So I guess coming back to you, Bob, where do you think the field's heading in from the diagnostic space?
So maybe just a question for the audience first. So how many of you are in regular follow-up with a specialist for celiac disease? So I don't see very many, maybe 10. How many are in the audience? Okay, so a minority. So what do you achieve by getting the follow-up? I mean, you're often faced with a battery of tests, looking for micronutrients, looking to see whether your antibody test is still positive. We know most of those tests are going to be normal, and part of the issue is that people still don't feel particularly well, even though all the blood tests are showing normal. And for me, my epiphany, if you like, was when we were doing one of the trials for NextVax 2, and we thought that we could include a biopsy at the beginning of the study to try and filter out the people who still had villus atrophy, so ongoing damage in the gut. We didn't really want people who had poorly controlled celiac disease. And so we took these biopsies and sent them off to a reputable lab with a reputable pathologist to review the biopsies. She only picked out maybe 2 out of 20 that she thought had villus atrophy. We then sent the biopsies off to a very extremely meticulous lab, probably the best in the world, in Finland, and they reviewed the biopsies from these people. And they found 60% of the people had villus atrophy, which had not been detected in the standard lab. And so that was a real eye-opener for me, was that the quality of the biopsy interpretation is such that you can't really pick the people who have continuing villus atrophy. And in the end, out of about 100 people that we'd enrolled in our trials, we found that 60%, whether it was New Zealand, Australia, or the United States, they still had villus atrophy, even though they were called well controlled. And then nearly all the remainder have what we call MASH2, which is still injured, not normal. And there was maybe 1 or 2 out of 100 who had a truly normal intestine on what we thought was a good gluten-free diet. So in terms of, what are the diagnostics that we need, and how do we make it worthwhile people with celiac disease on a gluten-free diet coming back for a review? And so one of the things that really needs to be done is better quality assurance for the biopsies. So we know that biopsies are often not collected by the gastroenterologist or surgeon or whoever's doing the endoscopy. They haven't followed the guideline for the right number of biopsies in the right places. That would be pretty easy to improve upon. I had a patient referred to me in Mackay. The surgeons had done the scope. They sent 1 biopsy off, and the biopsy was what they called denuded. It meant that the lining of the intestine had been scraped off. So you couldn't determine whether, the pathologist couldn't interpret it, basically. It was a waste of time. So I had to repeat the biopsy, do a 6 weeks challenge. It was tedious and unnecessary. And so the quality of the endoscopy could be improved. The quality of the lab looking at the biopsy could be improved, because we know that unless you align the biopsy and see the whole of the villus, you can't interpret what the damage is. Pretty easy, I would have thought, to improve upon that. So the follow-up biopsy, in principle, is a really important part of managing a long-term gluten-free diet. But the way it's conducted is, in many cases, a waste of time at the moment. So if you had going back to your question, if you had a blood test that you could tell the same thing, it would be great. Many of you will have had the antibody test, the transglutaminase test, as something that you do as a routine every couple of years to see if everything's normal. So it was found merely 15, 20 years ago that the antibody test is pretty much a waste of time in terms of people on a gluten-free diet detecting whether or not they have villus atrophy. If the blood test is positive, then it almost certainly means there's ongoing damage. But many people with a normal blood test will have villus atrophy. So we've been working together, Jason's lab and the company that I set up a few years ago, to develop what we call the whole blood interleukin-2 release test, which is a complicated name for a fairly simple test. It simply detects whether there are T cells reacting to gluten circulating in the blood and how many are there. It's likely, I think, that in the future, severity of celiac disease will be judged by the strength of your immune reaction to gluten. And some people we know in our studies, and Jason's doing a lot of these studies, you feed them gluten, not much happens. They feel tired, a bit nauseated within 3 hours. Other people, very different, and they are throwing up violently. And it really makes you appreciate that celiac disease is a severe medical condition in the right circumstances. And some of these people we were hearing about cytokines in the blood before. So we made this really quite significant discovery that you get what's called a cytokine release when you eat gluten if you have celiac disease. And you can measure these cytokines in the blood. So the answer, I think, is where is diagnosis going? It's shifting from semi-subjective markers like what's happening in the gut to quantitative markers that minimize the discomfort to the patient who's having the test. So I think what we call non-invasive biomarkers is the future. So yeah, that's a long answer, but in the short term, maybe Jason's probably the person in the whole world who's done more gluten challenges on people in research or in clinical practice than anyone else. But what's your take on gluten challenge? I know you mentioned it before, but
Yeah, and I apologise for doing so many gluten challenges and inflicting so much misery on so many people. I think it's a really important topic. It's the gluten challenge has an important role in clinical diagnosis and research and advancing new drugs. And so I think a common question though is, well, if I've been gluten, what does that mean? Is that bad? And some doctors will tell patients, oh, if you keep getting gluten, you're going to get a lymphoma, and all these horrible things will happen. So I think it's important to have a bit of context around that. And so short-term gluten challenge is safe, but it can induce adverse symptoms. It can make people vomit or get diarrhea or abdominal pain or nausea or have headaches. Lethargy is a prominent one. But after a single dose, typically symptoms will resolve. It can take several days, sometimes a week or more, for the lethargy to go away, and it's very, very unpleasant. But there's a great variability in how people respond. So as I mentioned before, some people don't have symptoms, some people at the severe end of the spectrum. And when we look at studies that undertake gluten challenge in people with celiac disease, it's quite remarkable. If you were to get people and feed them 2.5 slices of bread a day for 2 weeks, and you were to then look at their small bowel to see how many got deterioration, only a third to a half would get the classic villus flattening of celiac disease, and some will have virtually no changes. And often it takes a month before the antibody levels rise up. So antibodies are probably not a good reflection of gluten exposure, and it takes a long time for that gut damage to change, and it's very variable. And even though we talk about, oh, you need 6 weeks of gluten to get the diagnosis, we've certainly got patients sometimes that need longer than that in order to induce that gut damage. So there's great variability between patients. And one of the striking findings that Bob's talked about is this interleukin-2 level, which the height of that elevation tends to correspond to the severity of people's symptoms. So we're now trying to minimise gluten challenge in studies just because it is very unpleasant. So coming back to sort of what is the big significance, we know that the dreaded complication that people fear is the lymphoma or the T-cell lymphoma in celiac disease. And we know that at a population level, the risk of that is increased in people with celiac disease to about 7 in 1,000 over a 10-year period. So it's relatively low. Now, if you heal your gut on a strict gluten-free diet, that falls to around 4 in 1,000 over a 10-year period. If you have persistent damage in your gut, the persistent villus flattening, it's around 10 in 1,000 over a 10-year period. So the risk going from 4 to 10 means you double your risk if you don't get healing of the gut, but the absolute risk is still very low. So hopefully I made my point clear that even though you go from 4 in 1,000 to 10 in 1,000, and that's a doubling, more than a doubling, 10 in 1,000 over 10 years is still a very, very low number for the likelihood of you developing lymphoma. So whilst unfortunately accidents and exposures happen regularly for people following a gluten-free diet, in an isolated fashion, the intermittent exposure in the big picture probably doesn't have a big impact on things like lymphoma risk. So that's reassuring, but we wouldn't be comfortable with long-term gluten exposure, which is obviously going to lead to more substantial damage. So why is it important in drug development? Well, measuring the gluten response is an important thing to do when you're trying to develop a drug that aims to block it. So we are now in this era of developing new drugs that aim to protect people against gluten-induced symptoms and gut damage. And so we need reliable ways to show that the drug can effectively do that. So, and we'll probably touch on this in a moment, but there are a lot of drug trials now that are happening, and many of them will invite people to undertake a gluten challenge. And whilst this may not be appealing to many people, it's such an important part of the trial, because if we really want to know if that drug's working, giving a standardised amount of gluten and seeing if it protects you against the effects is the best way we can measure that protection and ultimately advance that drug through the pipeline. So gluten challenge is not something that we do because we like doing it, but we do it because it's enormously informative for this process of developing new drugs. And the hope is in the future with these new diagnostic approaches, we won't need to do gluten challenges in people who've gone gluten-free before diagnosis. Maybe we can do the testing on people whilst they're still gluten-free. And our study utilising this technology in people in Australia, and we've tested now over 70 people with celiac disease and about 80 people without celiac disease. This is a blood sample from someone on a strict gluten-free diet, so they have negative celiac antibodies, and more than 90% can be detected with this immune blood test without them having to do any gluten challenge, and it's very, very specific for celiac. So the exciting thing is, I think, moving forward, there'll be ways where we can minimise gluten challenge, but I think it will still be very important as part of drug development. So perhaps on that note, Bob, do you want to maybe tell us where the field's heading with drug development in celiac disease?
Yeah, I think part of this whole process of beginning to think about something additional to diet has actually led to a really careful look at the gluten-free diet. So 10, 15 years ago, the theme of many groups like this was how do you live gluten-free? And it was like, well, that's the only option. So you have to make it stricter. And the realization, I think, is that many people are following a strict gluten-free diet, but when you really look carefully, there's evidence of, if you like, partial recovery on gluten-free diet, but it's very rare to get full recovery. And I get quite angry, actually, when I read papers now claiming that healing occurs in 90% of people on a gluten-free diet. It's typically a reflection of the pathologist who they've used to look at the biopsies, and they've not made efforts to make sure that the pathology was done in the best possible way. And so we've sort of been conned a bit, I feel, by the gluten-free diet being a cure. And it's not a cure, you still have celiac disease. And what we began to realise with these gluten challenges is that people are doing their best on a gluten-free diet, but they'll be fed the cheesecake. And it's obvious that you're sick when you eat the gluten. So the immune reaction is still there. You've got improvement in the gut, but you've not got a normal gut. And therefore, something needs to be done. And so one of the reasons I got interested in celiac disease in the first place was that it offered a condition that you might be able to really understand at a very molecular level, but then begin to build medications that could go with a gluten-free diet. And at this stage, no one's proposing a replacement of the gluten-free diet. It's just a way to make the gluten-free diet work better. And so the first drug being developed for celiac disease began in the early 2000s. It was Alessio Fasano's work targeting gut permeability. It turned out that was a bit of a cul-de-sac. It didn't really go anywhere. And people spent $200 million developing a drug. It was never clear whether it really worked. But it did instruct people in what's the process to make a drug for celiac disease. And the drug that we designed, NextVax2, was the first of the immunotherapies for celiac disease. And we've learned a huge amount from those development programs. We've learned all about the cytokine release and the acute symptoms and how to measure them and what have you. Now I think it's about 30 different drugs are in development, maybe 10 to 15 are so-called in the clinic. So people are volunteering for studies receiving them. There's a range of targets for these drugs. Some are by mouth, some would be by injection. None of them are in the final stage of clinical development. We have probably perhaps 3 years before the first drug might be approved by the FDA. The Food and Drug Administration in the United States will ultimately make the decision whether a drug becomes available to patients in the United States. Whatever happens at the FDA in the end trickles down to New Zealand, Australia, everywhere else. FDA is in the driver's seat, really, in terms of what's approved. When there is a drug approved, we need to be ready. So we need to know who actually has celiac disease. So it's not going to be, oh, everyone on a gluten-free diet, here's a drug for you. It'll be, okay, so you're on a gluten-free diet, do you have celiac disease? And if you're on a gluten-free diet, it's actually quite hard to work out sometimes if you do have celiac disease, because you're going to go back to Jason's clinic and he'll say, I've got some bread for you. And there is some really promising work showing that the interleukin-2 levels go up within 2 to 4 hours after eating a slice of bread. So maybe you only have to have one exposure to gluten, and that could be your confirmation of celiac disease, or it could be the blood test, as we were just saying. So in terms of drug development, it's actually that there's almost like a menu of different drugs which are going to probably become available. You as a group, Celiac New Zealand, will have to become advocates. You know, you're going to have to go down to Wellington, or maybe it's in Auckland now, but perhaps in Wellington, and you're going to have to go and lobby government to pay for these medications. So some of them are going to be very expensive, some might not be very expensive. Some might be, if you like, entry-level drugs that you take by mouth, and then if that doesn't work particularly well, you might move on to the next level of medication. So I think where we are now is there's a critical need for people to volunteer to be in trials. Marilyn Geller and the CDF in the United States have developed a very, very powerful registry that people can use to show that they're willing and perhaps eligible to be in drug trials. It's a global initiative that's developing now. The other part is going to be we need to develop better diagnostic tests so that we can filter out, if you like, lifestyle gluten-free diet or irritable bowel gluten-free diet from T-cell celiac disease. So that is hugely important, and the work that's going on in several centres is directed towards that. So I think, sure, you need to be enrolling and thinking about whether you want to be enrolled in drug trials, and there are very good sites in New Zealand that are recruiting very efficiently, changing the world for celiac disease. But for the doctors amongst us and the people who are interested in follow-up, it's keeping the documentation to show that your biopsy actually showed you had celiac disease and that your blood tests were consistent with celiac disease. And we've found in some of the trials, when we started looking at interleukin-2, in the first study, I think it was, Jace, 2 out of 20 of your recruits didn't have celiac disease. And they returned to I think it's true, they're still on a normal, unrestricted diet, and they were diagnosed by biopsy. So we have a problem. It's just whether we care to really interrogate it now or later.
Yeah, and I think that's an important point. From that study, those individuals had been diagnosed based on villus flattening on a biopsy, but they'd never had the blood test, the celiac antibodies, to show positivity. And what we really know now, and Dr. Rostami, who's in the audience, has done a lot of work on this as well, is really that the villus flattening of celiac disease is not unique to celiac disease. There's a lot of other causes. Medications, like there's a blood pressure medication called olmesartan that can cause villus flattening. Infections, a range of other immune conditions can cause that villus flattening. And so that in isolation does not equal celiac disease, and there have been people diagnosed with celiac disease based on the biopsy alone. So having the positive blood test or having other features that support the diagnosis, including consistent genotype, is very important to really establishing that diagnosis. And in that study, those two people who didn't have the interleukin-2 response, we said, oh, that's a bit weird, and we asked them to go back onto gluten, which they reluctantly did, but then realised they weren't actually sick with it, and then they had pristine normal biopsies at the end. So in retrospect, one likely had a Giardia infection that caused the villus flattening, and the other one we never really worked out what was the cause, but it was clearly transient. But I guess to sort of expand upon Bob's points around how does a treatment help with a gluten-free diet? And so this idea of adjunctive treatments really could be that, and one of the most advanced drugs in development at the moment is an enzyme that degrades gluten. And so the notion here is that perhaps you can have this as an oral therapy to protect you when you're eating out at places where you might get contamination. For example, if you're eating away overseas, or there's non-English speaking places that don't really understand what you want. Or if you have non-responsive disease, in other words, you have persistent villus flattening or symptoms despite a strict gluten-free diet, maybe you could benefit from this because the presumption is maybe you're ultra-sensitive to low levels of gluten. So this sort of approach is what's really the initial target for drug developers, because we see this as viable and likely to succeed. But I think the holy grail, and Bob said, it might be very difficult to reach this, is allowing people to come back to a completely normal diet. And of course, I don't think we should give up on the hope of one day achieving that. So I guess maybe to throw that back to you, Bob, I mean, that to me would be, the ultimate goal is to treat people to reset their immune response to allow a normal diet. But what about preventing disease? What do you think might be the best way to approach that kind of outcome?
Yeah, so honestly, I think cure is unlikely. It's really difficult to reverse established immune responses. The drug therapy, though, it's a way, I think, of shifting your reactivity from, for example, 10 milligrams of gluten if you eat it, and feeling sick if you have 10 milligrams of gluten, to having 500 milligrams of gluten, and that causing problems. If you could safely allow exposure to 500 milligrams, you've probably covered the level of gluten that will occur in cross-contamination. So inadvertent cross-contamination is really the target for drugs. It's not going and wolfing down a pizza. And if we can achieve that, it's very similar to what's been achieved for things like peanut allergy. So peanut allergy treatment, which has been approved recently by the FDA, they simply showed that if you did a peanut butter challenge, the person didn't have an anaphylactic reaction when they had, 200 milligrams. But they did have a reaction before the treatment to 10 milligrams. So you've shifted the dose response curve. And that would be a tremendous goal. So you've definitely damped down the reaction. And we know that that's achievable really because we already see people like that. There's an interesting study that we're both involved in Brisbane, trying to work out the threshold that people react to. It appears that the threshold that different people with celiac disease react to is really quite wide. So there are very strong reactors at very low levels of gluten. There are others who don't react, but they do react at high levels. Prevention, on the other hand, is, in mice, a lot easier to achieve than it is treatment. So one of the reasons I think it's likely prevention will be successful is simply the fact that We know from studies, epidemiology studies in Europe, that the prevalence of celiac disease has gone up dramatically in the last 50 years. So there's something environmental which has changed the baby's immune system, because it's really babies that develop celiac disease. So something is changing. The immune signals allowing celiac disease to occur have changed in a negative way, along with having more autoimmune disease. But it probably means, almost certainly means, that you could reverse that. And so there was one very high-profile study supported by the European Union called Prevent CD, feeding small amounts of gluten to children at quite an early age. Complete failure. And it was probably because they didn't understand the immunology. They didn't have tests that they could have run to really, if you like, improve the design of the study. However, it's well known that for allergy, for example, if you are feeding small amounts of these allergens or antigenic proteins from an early age in small amounts, you can prevent diseases quite effectively. And so collectively, and I'm talking to Marilyn about this and others, it's whether groups like the one that I'm the president of, the International Society for the Study of Celiac Disease, we actually all get together, and this is one of the really big challenges in celiac disease globally, is getting everyone together, patient groups, scientists, clinicians, the whole lot, and pool our resources into big studies that are expensive, but the outcome is dramatic. So celiac disease is preventable. We need the key specialists to instruct the design. We need the funding, but it's doable. And so I see probably in the next 20 years, prevention will be the big thing achieved along with drugs to go with gluten-free diet.
And on that point of bringing people together, just a plug here, but in 2026, there's the International Celiac Disease Symposium. This is the preeminent celiac disease meeting that brings together celiac disease scientists, clinicians, researchers, patient societies, but also people with celiac disease from the community, and talks about the latest topics in celiac disease and provides the latest updates. And so I'm organising that in Melbourne in November 2026, and there will be a big patient focus, and so book your tickets to come in a couple of years to Melbourne. So on Bob's point about prevention, I think we've done some work looking at factors, and we're involved in an ongoing study looking at children who have a parent with type 1 diabetes, and obviously they're at risk of, this child is at risk of type 1 diabetes. And the study started before the child was born. It started with studying the pregnant mother, and then it has followed through will follow for 10 years that growing child, looking at the factors that might lead to their development of type 1 diabetes if they happen to develop it. And this study has been remarkable because it's been a really strong insight into not only the factors that might lead to type 1 diabetes development, but more to the point, celiac disease development. And in fact, there's 3 times as many celiac disease children developing celiac than type 1 diabetes in this study. So it's going to provide us with a wealth of data around different factors, and we know that factors from this and other studies include infections as triggers for celiac disease. The amount of dietary gluten, particularly before the age of 5, has been associated with increasing the risk for celiac disease development in genetically at-risk children. And hopefully moving forward, we'll learn about more factors so that we're in a position to prevent disease. But a common theme is that anything that disturbs the gut microbiome, and I'm sure you've heard of that before, and I know Karen mentioned that, the gut microbiome being the community of microorganisms that live in our gastrointestinal tract that play a huge role role in not just fermentation of food, but a diverse range of processes like metabolic processes and immune function, that things that disturb the gut microbiome, like infections, may trigger or unmask celiac disease in those genetically at risk. And a colleague in Sweden, Daniel Agard, is doing a trial where children who are genetically at risk of celiac disease are receiving probiotics to try to stabilise their gut microbiome, and they're showing some interesting data. So I do agree with Bob that attempts to prevent disease in the future will be very important, and I think ways to identify those at risk will also need to accompany those attempts. So I guess our plan was to really talk for around 40 minutes. I don't know if you have more to sort of say, Bob, now, or if we should open it up, because we'd love to be able to take questions.
Sam is poised.
Yeah, I've been told that you guys are hitting all the right notes, because the questions are just flooding in. So do you mind if we address some of those?
Sure. Yep. But no specific patient medical questions, please.
So we've had quite a few questions about the genetic testing and specifically about the DQ2 and DQ8 tests, and about whether they should be incorporated with testing and whether they can impact the kind of severity of symptoms.
Well, I'll crack at that one. So the big discovery, 1989, Ludvig Solid in Norway, showed that HLA DQ 2.5 was found in about 90% of people with celiac disease. And then they were able to show that many of the other people had this thing called DQ8, which is the same genes but different variant. And then gradually it was discovered that people who are what we call DQ 2.2, they also had celiac disease. If you have a double dose of these genes, particularly DQ 2.5, you had a risk of about 1 in 5 of developing celiac disease. So the risk if you're a DQ 2.5 like me is about 1 in 20 if you're in New Zealand or Australia. The problem with the gene test is that we gradually find more variants of those genes in people with celiac disease. There's what we call a half DQ2, it's really DQ7. And we spotted some people in the trials, and they had really strong couple had really strong reactions to gluten. So we're gradually finding more genes going with celiac disease, and that weakens the value of the gene test to exclude celiac disease. So it's of very little value to say you do have celiac disease. It has been very valuable to say you don't have celiac disease. And therefore, in terms of a workup for celiac disease, it's useful in cases that are uncertain. And so you can sometimes prove that it's almost certainly not celiac disease. So its value in standard workup is not great unless someone's on a gluten-free diet. And a problem if you're on a gluten-free diet is that the other markers of celiac disease normalise. So it's particularly useful in people on a gluten-free diet. But I think Jason will show up with his loaf of bread eventually.
Cool, thank you. We've got another question about whether there's studies done by you or that you're aware of about the cross-reactivity of celiac disease with other grains, dairy, or other allergens.
Oh, this is definitely Jason.
Okay, so there is a little bit of evidence that there are gluten-free cereals that have sequences in them, amino acids or protein sequences that look a little bit like gluten, and the question is whether these could mimic gluten in the real world. And we have a research study underway at the moment. We're collaborating with some cereal scientists at CSIRO in Australia to understand that question. So I don't think there's enough data to really comment on that. I think there's a lot of interest to understand, could there be other things in our environment that keep our celiac disease active? And for example, we've also shown that the bacteria Pseudomonas looks a little bit, parts of its protein coat look a bit like gluten, and so it can trigger the gluten-specific T cells in people with celiac disease. So I think we're moving towards a future where we're trying to understand different environmental factors, be they dietary or microbial, that might be important in keeping celiac disease unhappy, and hopefully we can target that to the right people who need that management in the future. But right now, no, there's not enough evidence to say there's other things outside of gluten that have gluten-like effects for now.
Yeah, I mean, honestly, I think a lot of that research is quite dodgy.
Thanks, Bob.
Yeah, no, not yours, but it's like, I don't believe that reacting in a test tube means that it's clinically important in a patient. So I think in the end it comes back to, can you feed the stuff or do something to the patient in a study to show that they really are having ill effects from it? And we, in the literature, in the dietary gut literature, there's lots of stuff showing that in a test tube things react. But honestly, if you took your poo and put it with blood, you get a really strong reaction. But
Don't look at me, Bob.
like, not yours specifically, but... So it's kind of like there are lots of bad things in the bowel, but they're in the bowel. They're not in your body. So anyway, that's just one of my irritations.
We've probably only got time for one more question, but again, we'll circulate some Q&A afterwards. But in a gluten-free celiac household, how much gluten should you feed a non-celiac child to avoid a diagnosis being missed?
As a sort of long-term gluten exposure before testing? No one knows. I mean, it's just... You can, and what sort of gluten? I mean, it's, if you're on an unrestricted diet and you're including wheat-containing foods, in the end, you're going to do the serology test. And we know that children in infancy anyway convert from being negative to being positive later. If there's a really high suspicion, then I think you'll have an unrestricted diet, but you'll and the paediatrician Andrew Day here and others, it's that you're not going to do the test once in a high-risk child. And maybe this is where the gene test is helpful. So you can stratify the risk. If you know that someone's a DQ2.5 homozygote, there's a 1 in 5 risk that they'll get celiac disease. And it probably justifies, many tests. If it's a person who is a low risk but susceptible DQ8, maybe you do it only once and it's negative. But some people develop celiac disease later in life, maybe at the age of 10 or 12. So you need to keep an open mind, and I think if there are symptoms, then you do the test. Because you can never be quite sure how much gluten someone's eating. It's funny actually, when you do a biopsy for celiac disease, it's not often that the gastroenterologist will actually ask the patient what they're eating. And I've seen several patients now in Mackay, and they've had, I think, in the end, like 3 sets of biopsies and 3 lots of serology. The serology was positive the first time, the biopsy was normal, the serology was negative the next time, the biopsy was negative, and then I fed them or asked them to eat 10 grams of gluten every day for about 6 weeks, and it was clearly positive. So, vital gluten, if any of you have encountered that, it's a really good way of being sure how much gluten someone's eating, because they just add it into their diet and you can get a pretty confident biopsy result after a few weeks of eating that much gluten.
Sadly, we might have to draw a close to this chat, and I think that probably most people here will join me wishing we could do another hour, because it's just fascinating. And also to enjoy your passion and banter. Don't often have 2 professionals that can be so comfortable as to live in each other's houses. So join me please in thanking our doctors.